Hi, my name is Amer Zeidan. I'm an associate professor of medicine in the hematology section at Yale University and the director of hematology early therapeutics research. I am here to talk to you about the next steps or future directions in the management of acute myeloid leukemia, expanding on a talk I gave in the recent SOHO meeting 2020. So I think there are several important developments that are happening in the acute myeloid leukemia field. We had a therapeutic revolution over the last 3 years with 9 new drugs that have been approved in the US for different indications within this disease space. And I have outlined several, I think, directions in which the treatment of AML is likely to change. The first direction is, I think, increasing rates of treatment of patients who are older with acute myeloid leukemia. So we and others have published several large population type studies and registered studies showing that in the US, and as recent as the year 2013, more than 40% of patients who are 65 years and older in the US are not being treated for their acute myeloid leukemia, and they just receive supportive care. And that's related to several factors. One of them is the lack of availability of great drugs, because historically we used either intensive chemo, and in the mid-2000s, hypomethylating agents were introduced. But the median survival with hypomethylating agent monotherapy is 7 to 8 months. And because it's injectable and requires frequent visits, many patients and probably their physicians opt not to treat and use these agents, leading to high rates of treatment non-use basically in those patients. So I think because of the availability of many new drugs, I think the rate of treatment will become higher and higher, which will hopefully lead to change in the curve of the survival of disease, where currently the median survival of older patients is in the range of 2.6 months in the US. So I think that will probably change as more patients get treated. The second direction is on the front of new therapies. So we had several agents that have been approved. I think the most recent approval of oral azacitidine in the maintenance setting for older patients with AML. And there was an approval for oral decitabine version, but for higher risk MDS. Those oral hypomethylating agents are probably going to also become backbone for subsequent combination-based strategies. So we are really going in a direction similar to what happened with multiple myeloma, where the treatment is becoming mostly outpatient, mostly oral type of drugs, and probably going in the direction of doublets and triplets. Azacitidine and venetoclax has been shown in a recent publication in the New England Journal of Medicine to have a better survival than azacitidine monotherapy. So azacitidine and venetoclax, or hypomethylating agents and venetoclax, have essentially become a standard of care for older patients with acute myeloid leukemia. And this combination has become the backbone on which additional agents are being added. More than 40 trials are adding a third agent to this doublet. And I think more and more of those trials are going to become available. And between all of that, I think we are going to see more and more patients get treated. Another dimension that I discussed is increasing use of novel endpoints, such as complete response with partial hematologic recovery. Traditionally, the endpoint was complete remission, but we are using other endpoints. In addition to the CRH, I think MRD negative CR is becoming more important because we have more and more data suggesting that MRD negativity is important for long-term outcomes. And recently, an analysis before bone marrow transplant have shown that patients who have MRD positive disease, their survival could be improved by giving them intensive or myeloablative conditioning compared to non-myeloablative conditioning. So I think the use of MRD as a prognostic and probably a point of intervention in the therapy of acute myeloid leukemia is going to become more important. Of course, there are multiple issues related to which way of using MRD assessment, whether it's genetic or flow cytometry based, and what are the best time points and standardization and using determining which are the best cutoffs. But I think we are going to that direction. And I think between all of these developments and the introduction of many new agents, whether they are targeted agents, we are moving away from chemotherapy. Another important area that's being tested in myeloid malignancies, is including AML, are different forms of immunotherapy, including bispecific T-cell engagers, other forms of antibodies such as antibody-drug conjugates and immune checkpoint inhibitors, in addition to cellular therapies such as CAR T-cell therapy. All of those are being tested in acute myeloid leukemia, in addition to a large plethora of targeted agents. Of course, we currently have approved FLT3 inhibitors and IDH inhibitors, oral agents. We have venetoclax, we have glastigib, and more of those agents are going to be tested and combined. And I think all of this will lead to significant improvement in the survival of patients with AML over the next few years, and significant change in the natural history of this disease. Thank you so much.